Hey, 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 hey. Not Fat Albert. It's just Miss Candler. I'm going to be recording the rest of endocrine. If you have any questions about the diabetes section, just let me know. The rest of this endocrine stuff is all your hypos and hypers, and if you get one, you'll get the other because it's usually just the opposite. All right, without further ado, then we will get started on other endocrine disorders. We're going to start with this PowerPoint on endocrine disorders, which really goes over mainly your pituitary disorders. Okay. And it's time to get going. All right, just a little review. It says, do you remember? And it has the hypothalamus that's located on the top layer. And the hypothalamus has a lot of control. And really, everything on this first line comes from the hypothalamus. Now, you see a lot of HRs, that's releasing hormones, and then you see IH, and that's inhibiting hormones. So it's got a releasing hormones and inhibiting hormones. So there's lots and lots of things that can come from the hypothalamus. So if something's wrong with the hypothalamus, we can see where we can have pituitary disorders because we are not secreting, inhibiting, or releasing hormones. Now, the second layer here is a hormone secreted from the anterior pituitary. So anything on this second layer right here comes from the anterior pituitary. So if something's wrong with the pituitary, we can have problems because we're not going to be secreting ACTH, FSLH, TSH, growth hormone, MSH, or prolactin. So we can have issues here. We can also have issues here with the actual organs because they actually target some of these hormones, the adrenals, the ovaries and testes, and the thyroid. And because they do that, we can have problems with the thyroid. If we have problems with the thyroid, then we just work backwards. We would expect to see, like, for example, here, increased TSH levels. Why? Well, if you think about it, if something's wrong with the thyroid and it's not secreting T3 and T4, this thyroid stimulating hormone is going to be beating this thyroid to death trying to get it to. Even though it's not going to, it's going to try to get it to. So you would see an increased TSH levels. Excuse me. So that's why they draw TSH levels a lot of times, if they want to see if something's wrong with the thyroid. All right, one last thing. These first four hormones here, ACTH, FSH, LH, and TSH, are all called tropic hormones. And they're called tropic, T-R-O-P-I-C, tropic hormones, because they exert their effect directly on an organ. So if you think about it, ACTH goes directly to the adrenal glands, FSH and LH directly go to the ovary and testes, and TSH goes directly to the thyroid. So these four are called tropic hormones, okay? These other three over here are called non-tropic hormones. That would be your growth hormone, your MSH, and your prolactin. Okay, non-tropic means they are stored in nerve tracts of the pituitary, and then they're just released when they are needed. One of the big things you need to remember, and this will come in real handy when we talk about the adrenal disorders, is that MSH is responsible for pigmentation. MSH is responsible for pigmentation. It goes hand in hand with ACTH. So if ACTH levels are increased, MSH levels are increased. If ACTH levels are decreased, MSH levels are decreased. And that's all I want you to remember about MSH. It's two things, pigmentation, and it has a direct relationship with ACTH in that it goes the same direction. So, in a nutshell, the nervous system receives and reacts to various stimuli that's transmitted to the hypothalamus. The hypothalamus then responds to the stimuli with the production and release of releasing or inhibiting hormones. which are then transported to the pituitary. So we start out with remember the hypothalamus. We've got either inhibiting or releasing hormones. Those are transported to the pituitary. And then in the pituitary, those factors either stimulate or inhibit the release of certain hormones, either the tropic or nontropic. Looking at diagnostic assessment in general, we know that there are different tests that can be performed. One of the things you're going to see a lot of is stimulation versus suppression test. And if you'll get your book and you'll open it to page 1364, I'll open mine as well. On page 1364, and then I'm going to get my glasses because I'm in denial. All right, on page 1364, it says, under laboratory and diagnostic procedures, fourth paragraph down, if hormone deficiency suspected, a stimulation test will be appropriate. During a stimulation test, the serum concentration of a hormone is measured before and after a stimulus, such as a drug, is administered. For example, an ACTH stimulation test may be performed to diagnose adrenal cortical insufficiency. During this test, a baseline measurement of your serum cortisol is obtained. Then a dose of synthetic ACTH is administered. A serum cortisol level then is obtained at a specific time, and the change in cortisol level from baseline is calculated. A failure of the cortisol level to rise appropriately in response to ACTH indicates primary adrenal insufficiency. In other words, something's wrong with the adrenal gland that no matter what I give it, it is not going to stimulate it to release cortisol. If hormone excess is suspected, a suppression test may be appropriate. In suppression testing, a hormone is known to inhibit a hormone is administered. For example, a glucose suppression test may be performed to aid in the diagnosis of growth hormone excess, such as acromegaly or gigantism. During this test, a baseline measurement of growth hormone is obtained. Then 75 to 100 grams of oral glucose is administered, and growth hormone is drawn at specific times following the glucose challenge. Since growth hormone secretion is normally suppressed by hyperglycemia, the failure of the level of growth hormone to decrease during that suppression test would aid in the diagnosis of growth hormone excess. And I'll explain that a little bit later and more in depth. Assays measure the amount of hormones, so we may have to measure our T3, our T4 levels. For example, if we're talking about the thyroid. So that is measurement of hormones. The urine test, talks about that on 1364 again, down at the bottom. We go in and we collect urine over a period of time. Usually we'll do what's called a 24-hour urine test. Now, some of these bottles have chemicals in them, so you have to be very careful when you're pouring in the urine in those chemicals, and most of them have to be refrigerated. So you'll go in, you'll start your time with the first specimen, pour it out, then you'll start from that time, and 24 hours later, you will collect during that time and keep pouring it in there. Like I said, you'll need to know because a lot of times those need to be on ice, so make sure that you understand that. Again, understand that there's chemicals inside those bottles a lot of times to preserve it, so you want to make sure you're careful that you don't splash that on yourself. Of course, always use standard precautions when you're emptying the urine into the container. They do that a lot when they're measuring particularly the release of the catecholamines with someone who has pheochromocytoma, which we'll be talking about. And they're drawing that to see if how much those metabolites are being spilled over into the urine. Lastly, we have radiographic or imaging exams, and that would be like your CT scans, your MRIs, things like that would help with diagnostic procedures. Okay, and we'll talk about those stimulation suppression tests with each one as we go along. So let's get started on the pituitary disorders. This is chapter 46 in your Med-Surg book, and this is chapter 29 in your Peds book. Let's start with the anterior pituitary. We know there's the anterior and the posterior pituitary. The anterior pituitary secretes these hormones. Remember which four are tropic, the first 4. That means they go directly to an organ down here. Remember, these 3 were non-tropic. They just travel in the blood until they and do their thing through the blood system. So the anterior pituitary secretes 70% of the hormones. The posterior pituitary, which we'll talk in a little bit, secretes only 20 to 30% of the hormones of the pituitary. The posterior pituitary secretes 2, oxytocin and ADH, and we are mainly going to be concentrating on ADH disorders. So what affects the release of pituitary hormones? Well, lots of things do. Medications can, certain meds. Your diet, your lifestyle can do that. For example, we know when we're stressed out that increases cortisol levels from the adrenal glands. Pathological conditions, if something's wrong with that organ, we may have an increase or a decrease of hormones. Which of the anterior hormones were tropic? That means they stimulate other endocrine glands. That should be tick, 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 ticking in your mind now. ACTH, TSH, LH, and FSH. Lots of terms there. Remember, it's the first 4. Something to keep in mind that's going to help you is that disorders are either going to be caused by undersecretion, which is hypofunction, or oversecretion, which is hyperfunction of these hormones that we're going to be talking about. Almost always, if you have a hyperfunction of any organ that we're going to be talking about, or any of these hormones, it's almost always caused by tumors. Now, hyposecretion disorders are a little bit more in depth. They can be something actually wrong with the gland itself, some kind of surgical involvement that mess with that gland, so that now that it's either overproducing or underproducing, and in this fact, underproducing. For example, if you take the thyroid out, if you remember, the parathyroids are located on the backside of the thyroid, so you can inadvertently mess with the parathyroids, therefore you're going to have problems with your calcium and phosphate levels. Genetic disorders can affect these, and sometimes tumor tissue pressing against it will. But almost always with hyper, it's related to tumors. So, on our adventure, we're going to discuss disorders of the nontropic hormones first. What was the nontropic? Growth hormone and prolactin. Growth hormone and prolactin. MSH, remember, I only want you to remember one thing about it. In MSH, all I wanted you to remember was it's responsible for pigmentation, and that it increases when ACTH increases, and it decreases when the ACTH level decreases. So we're not going to be concentrating much on the prolactin disorders, but we are with the growth hormone. So our first stop is the growth hormone, hyper and hyposecretions of the growth hormone. Well, let's review the functions of growth hormone, because that will help remember some of the things that it does and what some of the signs and symptoms we're going to see. Remember, growth hormone is a counter-regulatory hormone. Remember that? We talked about that in diabetes. So we know it increases blood sugar levels. But it also increases protein synthesis. It's responsible for breakdown of fatty acids. Like I said, it increases glucose levels, therefore affects metabolism, causes cells to grow, and it stimulates the liver to produce somatomins. Those somatomins actually enhance growth activities in cells and tissues, so they are responsible for bone and cartilage growth. So that's why we can get in some problems with bone and cartilage growth here. So our first stop is hypopituitarism, growth hormone deficiency. With growth hormone deficiency, we have a deficient secretion of growth hormone in children. That's always going to result in a condition known as dwarfism. Dwarfism affects about 1 in 10,000 children. Okay. Now, in adults, it's very hard to diagnose this because growth plates have already closed. So we start seeing an increase in the breadth of the bones, which we'll talk about later, and length of the bones. So mainly, hypopituitarism affects children, and it's a deficiency of growth hormone in children that results in a condition known as dwarfism. Now, this is usually usually diagnosed earlier in males than females. Why? Well, if you think about it, the evaluation of short stature in a male is of much more concern than that in a female with our society. So a lot of times they take them for referrals a lot earlier. Causes can be congenital, acquired from tumors, tissues, medications, but most of the time it's idiopathic. In other words, we have no idea in over half the cases. It can be because of something going on with the pituitary gland itself, such as postpartum hemorrhage, known as SIADH syndrome. And that's when the pituitary gland enlarges during pregnancy. And when hypotension results from hemorrhage, ischemia and necrosis of that gland will occur. Now, this condition usually develops immediately after delivery, but some cases can occur later on. Manifestations. Well, the presenting symptom is short stature. Height is retarded, of course, more than weight, but they're very immature in their appearance. They may have some dental eruption delay as well. Hair growth will be poor. They may have a high-pitched voice with sexual development being delayed, and the development of hypoglycemia. Why? Growth hormone is one of the counter-regulatory hormones. And that actually may be one of the first symptoms you see in the infant is a hypoglycemia. And you think they're coming in because of diabetes when it's actually a growth hormone deficiency. Diagnostic evaluation. Usually they're below the 5th percentile on the growth chart. That is a red flag when they start deviating from that normal. So if you see a child who's staying about that 5th percentile, barely hanging on to the norms, then that is a red flag. They're usually going to go in at that point and do x-rays of the hands and wrists for skeletal age and see if it matches their chronological age. Definite diagnosis is based on growth hormone levels, and how they will do that, a stimulation test. They're going to stimulate it pharmacologically with an agent. Growth hormone levels greater than 10, less than 10 nanograms per milliliter are positive. So it sounds like our first stimulation test. What are the agents? I've said that they will use some agents. What do I mean by agents? Well, if you think about it, what would stimulate the release of that? Well, if I gave insulin, insulin's going to decrease the glucose level. So with growth hormone being a counter-regulatory hormone, I would expect the growth hormone levels to increase in the presence of insulin. Other agents that also decrease that growth hormone level would be levodopa, propranolol, clonidine, but insulin is the most common agent used for the stimulation test. Insulin's the most common agent. So the stimulation of growth hormone involves injecting the client with regular insulin, so we know it's going to work pretty quick, and checking the circulating levels of growth hormone, because what will we expect growth hormone levels to do in the presence of more insulin that we really don't need? Increase. So with us expecting that to increase, we draw this level of growth hormone and it doesn't increase. Then we know that we have a growth hormone deficiency. Now what have you better be watching them for? Hypoglycemia, because we're giving someone some regular insulin, which is very scary when they don't have diabetes. So make sure you're watching their glucose levels very, very carefully. So if after giving insulin, growth hormone levels do not increase, the test is positive and we know a growth hormone deficiency exists. Therapeutic management of growth hormone deficiency, well, it's treat the cause, but oops, most of them are unknown. Over half are idiopathic. So definite treatment is just replacement of growth hormone. The drug of choice is somatotropin or somatotropin, and the success is 80 to 90% with these drugs. Now, somatotropin is given sub-Q, and you need to alternate sites. It's usually given at bedtime so that it closely approximates the physiological release of growth hormone, because usually growth hormone increases through the night and about 5 or 6 o'clock peaks. So you're trying to keep up with what the normal body does. About 9 years of age, they start to give their own shots with help. So they remember about school age, they should be giving about their own shots with help. Parents should be told that the child will grow the most during the first year, about 8 to 10 centimeters. And then after that, it's going to decrease. If you'll remember, 1 inch equals 2.5 centimeters. So that's about 4 inches total in the first year. Then it's going to dwindle down to about 1 to 2 inches yearly after that. Parents should be encouraged to interact with their child according to their age, not their size, because it's real easy to treat them according to size because they are very immature in their appearance. It is expensive, about $35,000 a year, and they do need lots of emotional support. They can be teased a lot. They can be called names such as short, shrimp, midget. They're usually picked last for sports, so they need emotional support and care. So let's say you're the school nurse and you've noticed some kids at school are teasing a child who's short because of growth hormone deficiency. They've even nicknamed him Fly. How would you intervene? What should you do? Well, think about some things that you can do. Big thing is educate. Educate, educate, educate. And a lot of times children just don't understand that there's something going on with that student. And I know lots of times children have preferred that someone go in and educate the class about what's going on. Other times they do not, so you have to have the child on board. But providing lots of emotional support to that child is key. There are community resources such as the Magic Foundation, Growth Hormone Foundation, and Short Stature Foundation. And if you don't think that plays a part in role in society, it does. Short stature, they even made a song about it years ago. Short people have no reason to live. It was bad. So if they're making even songs about it. So when would therapy stop and why? Well, let's think about that. It would stop when? We're sitting here giving it as this child's growing. I would think about the period right before the epithelial plate's going to close or the appropriate growth height is achieved. So right after their growth spurt should have occurred, you need to stop it, which is about 14 to 15 in girls and 15 to 16 in boys. Because if you keep giving it, what's going to happen? Acromegaly can happen. You're going to start having a broadening of those bones because now you're going to be getting too much growth hormone. So you want to make sure, again, that we do stop it at the appropriate time because we don't want acromegaly to occur. All right, then. That was hypo. So let's talk about hyperpituitarism, growth hormone excess, so an oversecretion of hormones, and in this particular case, growth hormone. One example is oversecretion of growth hormone, and the main cause. What is the main cause? Tumors. Remember, that should have popped right in your brain. We already talked about that. In the child, it results in what we call gigantism, and in the adult, it results in what's called acromegaly. Manifestations. Gigantism in the child, they will have abnormal increase in their long bones. They can get up to 8 feet tall. Height and weight exceeds 3 standard deviations above the mean. And unfortunately, they get a lot of organ enlargement. And actually, that's what causes a lot of their death. The hypertension, the heart failure can actually contribute. So what makes the difference in the signs and symptoms you're going to see in the child versus the adult here? Well, again, it has to do with growth plate closure in the adult that makes the difference. Once the growth plate has closed, that's when you see the acromegaly in the adult. And so anytime after adolescence, when that growth plate closes, acromegaly is going to result. The bones then are, instead of getting longer, are actually going to broaden. They're going to increase in thickness. They're going to increase in width. You're going to have enlargement of the soft tissues so that you undergo a lot of facial changes. Changes in ring and shoe sizes, and those will not reverse. So you will have to become acquired to your new sizes. Sometimes their feet will grow up to size 13s when they had like a 10. Headaches, visual changes, sinus congestion, and all that's got to do with the changes that's going on with the face. Kyphosis, sexual dysfunction can occur. If you look on page 1393 in your book, it shows you the patient with the developmental stages of acromegaly. You can see there in figure A, versus B, you can start seeing some broadening of her nose and some increasing longness of the face. And then you can see the coarseness and the broadening that's developed of her hands and her face in figure C. So that's a typical progression you would see in someone who has acromegaly. Now, in this syndrome, girls are usually evaluated more quickly than boys. Why? Again, the tallness of the boys is actually seen as an advantage, particularly in sports. So usually we don't have them checked out. Diagnostic evaluation. Well, you're going to have a history of excessive growth in the childhood, an increased level of growth hormones, X-rays and CT scans and MRIs are going to be done. They're going to be done to detect tumors because remember that's the #1 cause. Now, when I say excessive growth in childhood, now instead of being at the 5th percentile, these children stay above the 95th percentile. So that's a red flag as well when they're staying on the upper edge. Enlargement of the sinuses on X-ray. And now, instead of doing a stimulation test, we're wanting to do a suppression test because now we have too much of it. So what we will do is what's called a glucose load, okay? And what they're going to do with this suppression test is they're going to go in with a glucose load and will be performed on the growth hormone, but it will not be suppressed in the presence of the glucose load. So what they'll do is go in and give 100 grams of oral glucose. Then they will measure the growth hormone levels up to 120 minutes. Now, growth hormone levels should go down or below 5 nanograms per milliliter because if you've given a glucose load, then they've got plenty of glucose, then you should be suppressing growth hormone. Your growth hormone is a counter-regulatory hormone that increases levels. So if the level's already high, you would expect growth hormone levels to start going down. So if growth hormone levels do not go below 5 nanograms per milliliter, the test is considered positive in adults. And in the child, it should go less than 10. So in adults, it should be less than 5. In children, less than 10. If it's not, after that 120 minutes, then you know that it didn't suppress it and there's something wrong, that you have growth hormone excess. Okay? So what's our management? Return the hormone levels to normal or near normal. How do we do that? Through surgery. That's our treatment of choice. Radiation's not very helpful, and radioactive implants have their own problems. As far as pharmacological management, that's what we'll try. You have dopamine antagonist. Parladel is one of the drugs of choice, our main one that we use. And in children, high doses of sex steroids to close the epithelial plate early. Medications, these medications work by decreasing prolactin and growth hormone levels. So even though these are mainly used for psych meds, one of the things that you're going to find is that one of the FDA has written down that they decrease PRL, prolactin, and growth hormone levels. So we may use these prior to surgery to get those levels down. Side effects with these meds are orthostatic hypotension. They can cause some gastric irritation, nausea, vomiting. So you want to take them with meals. Now, of all the age groups, adolescents are affected the most by this. Why would adolescents be affected the most? Because of the adolescent growth and development stage they're going through. All right, so let's say someone has to have surgery. What they're going to have is transpenial hypophysectomy, and this is a complete or partial removal of the pituitary gland. I would suggest that you YouTube this if you've never seen this, and that you look and get better familiar with what they are doing. Preoperatively, they're going to make sure they've got clean nasal passages. They're going to be giving them antibiotic spray to make sure they don't have any kind of infection, getting baseline vitals and weight, and letting them know afterwards they're going to have some nasal packing. So a lot of pre-op teaching. They're also going to be teaching this time about potential post-op comps, and we'll talk about that in a little bit. Now, the bad thing is when you take out the pituitary, you affect all those other hormones. Remember, we're talking about a growth hormone deficiency, but all those hormones are in the pituitary. So when you mess with the pituitary, you got to go back to all those hormones that were on that line, and you may have to need supplemental therapy of all those hormones. So this isn't one of the things we want to start with doing. But what's going to happen when they go in and do a transpenial hypophysectomy? It's a microscopic surgery. The client will be under general anesthesia. They'll be in a semi-sitting position. The surgeon's going to go in and make an incision just above the upper lip until they reach the pituitary gland through the sphenital sinuses. After the gland is removed, a muscle graft is taken from the thigh to support that area and to prevent any leakage of cerebral spinal fluid. Nasal packing is then inserted after the incision is closed, and they'll have a mustache dressing then applied. And that's just a dressing above the lip. If the tumor cannot be reached by this approach, then they have to go in and do a craniotomy, but they will always try transpenial first. So, preoperative teaching also involves them not brushing their teeth, coughing, sneezing, blowing their nose, or bending forward after surgery. Nasal and mucous membrane swabs prior to surgery to make sure they don't have an infection. And again, they will have that mustache dressing. It is normal to have some wetness to that may appear 2 to 3 days later, but you want to make sure that it is not cerebral spinal fluid coming out. So I said earlier you want to teach them to watch for 2 main postoperative complications. What are those 2 main postoperative complications? One is diabetes insipidus, not to be confused with diabetes mellitus, DI, and increased intracranial pressure. Now, post-op day 1, let's say you go in and they are having output after output, and you're going, man, how are you putting out so much? And they're getting up to the bathroom constantly. They're complaining of extreme thirst. You probably need to call the physician because they are having diabetes insipidus, which we'll talk about in depth in a little bit. Now, for increased intracranial pressure, you're going to be watching for things like headache, nausea, vomiting, visual changes, restlessness, postnasal drips. You can keep the head a bit elevated, about 30 degrees, no more, after surgery, and that will help with this some. So, increased intracranial pressure, watching for headaches, nausea, vomiting, visual changes, restlessness, and complaints of postnasal drip. Now, diabetes insipidus, these people can urinate as much as 15 liters a day. So, always, when someone comes back from a transpenial hypophysectomy, first thing you do is put them on strict INO and daily weigh, because you're wanting to make sure they're not having this complication. All right, you're also going to monitor that mustache dressing for drainage. Clear yellow tinged fluid may be checked for glucose just to make sure they're not having it. A lot of times it'll have a halo-looking area on the mustache dressing. A light yellow color at the edge of the clear drainage also is a halo sign, and that indicates cerebral spinal fluid. So what you would do is go in and check that and see if glucose is present with the dipstick. Nuchal rigidity may indicate meningitis, and if that is present, we worry about them having infection, bacterial or viral meningitis, and of course you would notify the physician immediately. Nuchal rigidity, of course, being neck stiffness. Other conditions or considerations, you want to encourage oral fluids. They may have a temporary loss of smell because where that surgery is, and they went in and messed with some of the sinuses. Provide O2 and humidity and mouth care. Again, they're going to have to go in if they have done a complete pituitary removal and check all those other hormones, because you're probably going to have hormone replacement therapy for life. Head a bed up no more than 30 degrees, mild analgesics for the headache. And then again, to avoid that increased intracranial pressure, teach them not to bend over at the waist, not at the, it should be W-A-I-S-T, not that waist, not to bear down, cough, and not to lie flat. All right, you want to watch the child for excessive growth. Again, they need emotional support as well. Watch the adult who complains of the changes in their shoe, hat, and ring size. It just keeps getting broader and broader and larger and larger. And know that there is an acromegaly network association out there. Okay, prolactin disorders is another adventure. Begins, one ends. I'm not going to talk about this much. This is normal after pregnancy. One normally doesn't see hyposecretions, delayed puberty. It's only usually a secondary cause like gymnastics. So someone who does extraneous activities may not go into puberty like they should. One will usually see hypersecretions, and hypersecretions are related to tumors. So the main one we're going to be talking about is precocious puberty. Now, precocious puberty is on page 979 in your Peds book, and this is an abnormally early appearance of secondary sex characteristics. In other words, you're right before your time, right before your time. Causes are idiopathic, which means we do not have a clue for about 80 to 90%, and then a tumor, which is quite rare. There are two main types. There's the true, or also known as complete or central, and the incomplete. The true or complete precocious puberty is when we have a premature activation of the hypothalamic pituitary gonadal axis. In other words, that's the gonadal axis that usually kicks in during our growth spurts. But for some reason, theirs kicks in early and pre-activates so that they get secondary sex characteristics very early in life. Incomplete, on the other hand, is related to secondary to tumors. So it can be either type. So if I was looking at diagnostic lab, I would expect to see an increase in my LH and my FSH and my growth hormone releasing hormone. And they're going to be looking at growth bone and bone age as well. They're going to show early manifestations of sexual development. Boys before 9 and girls before 8, as young as 4. In boys, secondary sexual development before the age of 9. In girls, they can have breast at 7, pubic hair before 8, 8.5, menses before 9. And they are producing mature sperm and ova. That's very important. Now, I will tell you, if you think about this, the permanent complication of having precocious puberty is short stature. Why would they have short stature? Because of those excessive sex hormones. The body prematurely thinks that it is in growth spurts. So it tricks itself into thinking that, well, what do we know happens when you go through the growth spurt? After the growth spurt, the epithelial plates close. So you have a premature closing of the growth plate because of the excessive sex hormones. So short stature is a permanent problem with precocious puberty. If it's complete, you're going to treat the cause, removal of the tumor. If it's true or complete, then they've had that premature activation, and you've got to give them something that will suppress the activation of that gonadal axis. Daily injections, sub-Q, or monthly IM injections of what's called Lupron will actually help with that. Or you can give some intranasally, but Lupron is the drug of choice. When would treatment be discontinued? Well, it's discontinued at the time of puberty, at about 11 for girls and 12 in boys. So when those girls start about puberty, they're going to start they're going to let off of the Lupron, so that they'll go through the growth hormone, go through the growth spurt, and then they will actually shut off the growth plate at the right time. Anytime a child or an adult has an alteration in their sex hormones, the RN's going to need to help them cope with changes, so they're going to need lots of emotional support. Now, they still need to dress and participate in activities that are very age appropriate. They will have an increase in hormone levels, so therefore they're going to have an increase in sex drive. So teaching. These injections are not cheap either, about $10,000 a year. All right, the posterior pituitary. No adventure would be complete without a stop there. Remember, the posterior pituitary does not produce hormones. It stores and releases ADH and oxytocin. ADH acts on the kidney tubules to reabsorb water, thereby regulating fluid volume. That's very important to remember its action. Oxytocin stimulates uterine contractions and milk ejection reflection. So we're mainly going to be focusing on ADH, which acts on the kidney tubules to reabsorb water, thereby regulating fluid volume. I'm sorry, I'm starting to get a sore throat. Hypo and hypersecretions of ADH. Hypo and hypersecretions of ADH. Hyposecretions of ADH result in a condition known as diabetes insipidus. Diabetes insipidus. And because of that, we have uncontrolled diuresis. And we talked about that earlier being one of the side effects of a transperineal hypophysectomy. Hypersecretions of ADH results in a condition known as SIADH. SIADH, which stands for Syndrome of Inappropriate Antidiuretic Hormone. Syndrome of Inappropriate Antidiuretic Hormone. There are three types of diabetes insipidus. There's the neurogenic, which is the most common, and it's a problem with the hypothalamus or the pituitary. There's nephrogenic, which is an inherited disorder, and there's psychogenic, which is compulsive water drinkers. This is someone who drinks, and they have some underlying mental issues, so it's psychogenic. So these are the two main ones that we'll be dealing with, the nephrogenic and the neurogenic, and I'll tell you how to tell the difference here in just a little bit. Neurogenic is our most common, where we have a problem with either the hypothalamus or the pituitary. With nephrogenic, the renal tubules are actually defective. The renal tubules are defective. And of course, if they have the psychogenic, they're going to need psychological intervention, which is quite rare. Normally, thirst is regulated by ADH release. Okay, you get thirsty, ADH is released. ADH facilitates the concentration of urine. How does it do that? By stimulating reabsorption of water from the distal tubules of the kidneys. So when ADH is inadequate, the tubules do not reabsorb water, leading to polyuria. You just keep putting out the urine. Manifestations then is going to be polyuria, nocturia, and enuresis in children, bedwetting. Polydipsia, increase in thirst, and dehydration. These are your three hallmark signs of diabetes insipidus, and this can occur at any age. It can come on very suddenly and abruptly, and usually dehydration is what leads to the diagnosis of diabetes insipidus a lot. So in the infant, you're going to see things like irritability relieved by feeding of water only. They don't want milk, they just want water. In the child, you're going to see excessive thirst. They're going to be taking in 4 to 6 liters and voiding 4 to 10 liters. A lot of bedwetting. In the adult, you can see profound urinary output, 5 to 30 liters. I mean, you almost have to have a porta potty taped to you. And extreme thirst, 4 to 40 liters. And they quench the cold water. Weight loss and weakness, and which you can imagine. So you've got someone, man, I just keep urinating. And then when a red flag should go up in your mind, something's wrong, potentially diabetes insipidus. Would you expect the specific gravity and the osmolality of the urine to be increased or decreased? Well, let's think about this. They're urinating. It becomes very dilute because of all the fluids they're taking in as well. So if it's very dilute, then you would expect the urine to be decreased because you're measuring number of particles per solution. There's not going to be very many particles if it's real dilute. Would you expect the serum osmolality to be increased or decreased with diabetes insipidus? You would expect the opposite. Remember, they're dehydrated because even though they're drinking, that ADH is not working on the renal tubules to absorb it, so they're just pouring it out. So the serum was actually increased because now I've got more particles than I do water in the serum because I'm actually dehydrated because it's all going out in the urine. As the patient's blood loses water, we know plasma osmolality, increases because of the dehydration. In other words, you have more particles now than solution. If that doesn't make sense, then bring me a message and I'll get back with you. Diagnostic test, well, we're going to do what's called the fluid deprivation test. This is the simplest test used to diagnose this condition. You have to watch them, though, very carefully if you've never done a fluid deprivation test. People get desperate, just like deprivation, they get desperate. They will go to toilet bowls for water. They'll drink it out of the plants. They'll drink it from any source they can find, any one they can find. So you have to be careful and monitor them very closely. What happens? They have a restriction of oral fluids for up to 8 hours or until they lose 5% of their body weight. And observation of frequent changes in urine volume and concentration and weight have to take place during this time because this can be a very dangerous test. In diabetes insipidus, restriction of oral intake is not going to have any effect on urine output. But it increases the dehydration because now I'm not even drinking any. They just keep pouring it out, but now I'm not even trying to drink. So if it's positive, if let's say it's positive, okay, you've withheld 8 hours and they just keep pointing out lots and lots of fluids, then what you're going to do is give a test dose of ADH, 5 units of vasopressin. Okay, you're going to give 5 units of vasopressin. Well, if I give 5 units of vasopressin, because remember what's causing this? I don't have enough ADH down there on the renal tubules, so it's not reabsorbing the water. So if I give ADH, it should resolve the polyuria and the polydipsia because now I have the ADH on board that's down at the renal tubules that's doing what it should be doing. If it does not, then remember the 3 types I told you about earlier. The psychogenic, the nephrogenic, and the neurogenic. Then I probably have the nephrogenic type because even though I'm giving ADH, it's not doing any good. So something's wrong with the renal tubules themselves. That would be a hereditary thing, and that would be the nephrogenic type. So let's go over that one more time. Fluid deprivation test. Someone with diabetes insipidus who's outputting. They lack ADH on the renal tubules to reabsorb the water. So I withhold fluids. Even withholding fluids, I still lack ADH. So what's going to happen? I'm still going to keep urinating, and getting more and more dehydrated. But if I give a test dose of ADH, 5 units vasopressin, what should happen? Well, now the ADH is down there, so now I can start reabsorbing that water. So the polyuria and the polydipsia should go away. If it does not, I know that I have the nephrogenic type because it's not responding to the ADH no matter what. Okay? So you have to watch them very closely for vascular collapse during this test. Watch them very closely for vascular collapse. Management is to assure adequate fluid replacement. I know daily weight, vital signs, hormonal replacement therapy, it's going to be lifelong. They're going to be getting DDAVP, desmopressin. They can get that in the nasal form. They may be getting it oral, sub-Q. The side effects include ulceration of the mucous membranes. They can have allergies to it, chest tightness, and pulmonary inhalation. Usually once you take it, it lasts for about 8 to 20 hours, so it is good to take. Adequate fluid replacement because they're usually hydrated when the diagnosis is finally made. Now, how do I know if DDAVP is working? Well, if I give the DDAP, the desmopressin, which is ADH, and they are urinating fine, they've got a balance of intake and output, I know it's working fine. What happens if they start urinating a whole lot more? Then I know that it's not working and I might need to increase that dose. Let's say they're getting the nasal form. Well, what happens if they get a real bad cold, respiratory infection? Then doesn't it make sense that during that time I'm probably going to have to increase their dose more because they may not be getting the full absorption of that medication. Now, a major side effect of this is I can give too much DDAP and go the other way. If I go the other way, I can result in water intoxication and overhydration, so I may need to cut down if I see that occurring. So it's just a balance that you've got to try to find. Nursing considerations is early detection of the disorder. They're going to need a medical alert bracelet. School-age children, you're going to have to give them unrestricted use of the lavatory and drinking fountains. And know that during illness, they will need increased fluids and medications. So if you got that one down pat, you got this one down pat because it's just the opposite. SIADH is the syndrome of inappropriate antidiuretic hormone. This now we have excessive ADH secretion, whereas we didn't have enough ADH, now we have too much ADH. So it can be caused by different things. The big thing's tumors because we're over-secreting, but it can be caused by other things as well. So manifestations, now instead of getting rid of too much fluid, I'm retaining too much fluid because I have too much ADH. So now I have just the opposite, fluid retention. Sodium levels now are going to be low, less than 120. Abdominal cramping, irritability, headaches, personality changes, increased blood pressure, weight gain. And usually with treatment, most of these are reversed. Symptoms disappear when that cause is corrected. But immediate management, now instead of encouraging fluids, now I'm restricting fluids and diuretics, so just the opposite. So now I only want them to have about 500 to 800 meals per day. Nursing considerations is going to be daily weights and eyes and nose and monitoring labs. Watching for overload. Now I'm watching for seizures, explaining the fluid restrictions, which is not easy to do to anybody on a fluid restriction who's craving it, support, and accessing mental status. Reporting weight gain, they need to know to do that, and they're going to have a replacement of the sodium. So diagnostic test, looking at diagnostic test, sodium levels would be low. Serum osmolality would be decreased this time because now I'm overhydrated, so it would be decreased because now I've got too much fluid and I'm not putting out much. ADH levels would be increased, so increased ADH levels. And my urine osmolality this time would be increased because now it's concentrated. I'm not putting out much urine. So it's just the opposite of DI. So if you get DI down pat, you'll get this one down pat because it is just the opposite. If you think about bun and creatinine, well, I'm overhydrated, so bun and creatinine would be decreased as well. Now, this syndrome, again, is easily managed by eliminating the cause, medication, and putting them on medications. Okay, so if you get one, you get the other. If you have any questions, any concerns, nothing made sense, then let me know. Next stop, adrenal glands. Thank you.